epinephrine, and volume expanders. This video demonstrates how to draw up epinephrine and volume expander and administer them through an emergency umbilical vein catheter, or UVC. Epinephrine is indicated if the baby's heart rate remains less than 60 beats per minute after at least 30 seconds of assisted ventilation that moves the chest, preferably through an alternative airway, followed by another 60 seconds of chest compressions coordinated with ventilation using 100% oxygen. Epinephrine is not indicated before you have established ventilation that effectively inflates the lungs. Be sure you have the right concentration of epinephrine for neonatal resuscitation, which is 1 milligram per 10 mLs. This concentration is used regardless of the route of administration. You'll need a 1 ml syringe for intravenous administration. This is the preferred route during neonatal resuscitation. You will use a 3 or 5 ml syringe for intratracheal administration. These two different sizes of syringe serve as a visual reminder that epinephrine has two routes and two different doses. The 1 ml syringe is used for the smaller IV dose, and the bigger syringe is for the larger intratracheal dose. You'll also need a 3-way stopcock or a medication dispensing connector, medication labels, and something to write with. Let's prepare the intravenous epinephrine. For this 3 kilogram baby, the medical provider has ordered 0.2 mLs per kilogram, which is 0.6 mLs of epinephrine using the 1 milligram per 10 ml concentration for the UVC. The correct epinephrine usually comes in a box. Open the perforated end of the box. Remove the 2 pieces inside. Holding the devices with the yellow caps on top, flip off the yellow caps and screw the 2 pieces together. Attach the 3-way stopcock and attach the 1 ml syringe. Turn the stopcock off to the unused end, opening the stopcock between the syringe and the epinephrine vial. Give the epinephrine vial a push and fill the syringe. In place of a 3-way stopcock, you can also use a medication dispensing connector. Remove the syringe now filled with epinephrine from the stopcock or connector. Ensure that there are no bubbles in the syringe. Ensure that you have the correct amount of epinephrine in the syringe, which is 0.6 mLs for this example. Check your hospital policy for labeling code medications. If you set the syringe down or hand it to someone else, you should label it. Position the label so you can see how much epinephrine is in the syringe. It's every team member's responsibility to call out a possible patient safety issue. For example, if you notice the epinephrine is in the wrong size syringe for the desired route. Any team member may ask for clarification by saying, for example,
"Stop! The IV dose is in a 5 ml syringe. Is that correct?"
Then, the team would stop administration and double-check the route and dose. Now let's administer a dose of epinephrine for the UVC. The medical provider and medication nurse use closed-loop communication to order and administer the medication.
"Chris, this baby is approximately 3 kilograms. Prepare 0.2 mLs per kilo of the 1 milligram per 10 ml epinephrine, which is 0.6 mLs for the UVC."
You want epinephrine 1 milligram per 10 ml, dose 0.2 ml per kilogram for a 3 kilogram baby, which is 0.6 ml for the UVC.
Correct.
Nicole, I have 0.6 ml of epinephrine for the UVC ready.
Correct. Administering the epinephrine now.
Ensure that the catheter is being held in place to avoid dislodgement. Attach the syringe to the stopcock. Open the stopcock to the catheter and syringe, aspirate slightly to remove potential air bubbles, and administer the epinephrine rapidly. Now, turn the stopcock so that it's open between the baby and the normal saline flush. Gently flush the epinephrine through the catheter with 3 mLs normal saline. Turn the stopcock off to the baby.
Intravenous epinephrine given.
Now the recorder can acknowledge the intervention, document the time, and alert the team when 1 minute has passed to check the heart rate. Continue coordinated compressions and ventilations for 1 minute before checking the heart rate. Use this minute to ensure that there is chest movement with assisted ventilation, that compressions are 1/3 the AP diameter of the chest, and that compressions and ventilations are coordinated at the correct rate. Make sure you are ventilating with 100% oxygen. Plan your next steps if the heart rate does not respond to IV epinephrine. You may repeat the recommended dose of epinephrine every 3 to 5 minutes. Check the heart rate 1 minute after epinephrine administration. Continue ventilation. Briefly pause compressions. Discontinue compressions if the heart rate is greater than 60 beats per minute. Intratracheal epinephrine may be given while IV access is being established. However, the heart rate response may take longer or may not occur. Use a 3 to 5 ml syringe for intratracheal epinephrine and draw it up as previously described. Disconnect the ventilation device from the endotracheal tube and deposit the epinephrine into the tube connector. Endotracheal epinephrine does not require a normal saline flush. Reattach the ventilation device and continue ventilations and compressions. The recorder should acknowledge the intervention, document the time, and alert the team when 1 minute has passed since administration. If IV access is attained after intratracheal epinephrine was administered, and the heart rate is still less than 60 beats per minute, it's not necessary to wait 3 to 5 minutes before giving the intravenous dose of epinephrine. If there is not a satisfactory response after intravenous or intraosseous epinephrine, consider other problems such as hypovolemia and tension pneumothorax. Volume expanders should not be given routinely during resuscitation. However, if the newborn is not responding to the steps of resuscitation and has other signs of shock or a history of acute blood loss, volume infusion may be indicated. The initial dose is 10 mL per kilogram. The recommended solution for treating hypovolemia is normal saline. When severe fetal anemia is suspected, packed red blood cells should be considered. If cross-matched blood is unavailable, use emergency, non-cross-matched, type O, Rh negative red blood cells. To administer normal saline, fill a 30 to 60 ml syringe with normal saline or use pre-filled normal saline syringes. These pre-filled syringes are usually not in a sterile package, but remember that you may make modifications to sterile technique for this emergency procedure. The medication nurse takes the volume expander to the bedside and confirms the order. Volume expander is infused over 5 to 10 minutes by slow, steady push, or use a syringe pump. If the newborn is still not responding to resuscitation efforts, reassess the quality of your ventilation and compressions. Is the chest moving? Are there equal breath sounds? Is the airway obstructed by secretions? Is 100% oxygen in use? Is the compression depth 1/3 the AP diameter of the chest? Was the correct dose of IV epinephrine given? Is it time to repeat the dose? Is a pneumothorax present? A stat chest X-ray may provide valuable information. If necessary, call for additional expertise. Be sure to communicate with and provide support for the baby's family.